Very good evening, one and all. Very good evening, fellow doctors, seniors, juniors, ladies and gentlemen. Uh, we have gathered once again for an academic feast that is to follow. And I, Dr. Parthsarathy, warmly welcome each and every one of you. As each and every one of us know from our clinical practice, and with the latest ICMR INDIAB 17 data also being published, diabetes in the Indian scenario is nothing that can just be thrown under the pillow. With 101 million projected cases of diabetes and 136 million projected cases of pre-diabetes, this is just something that is already burst out into the population, and all the more calls for us to be more robust in our clinical practice. Further challenges to align as far as the Indian phenotype and genotype are concerned, as we all know in our clinical practice, we Indians having a much more higher CV risk, atherogenic dyslipidemia, so forth. So, without wasting any more time, I would just like to say that we have the best panel today who actually require no introduction in the field of medicine or endocrinology to take this ahead. And we also had the EASD updates, which were just out. So, to discuss more on the same and how it is relevant to us, I now call upon my esteemed colleague, Dr. Charmi Prajapati, to introduce our esteemed moderator for the day. Charmi, over to you.
Sir, and very good evening, one and all. We have with us Dr. Prameela Kalra as our esteemed moderator for the day. Ma'am is Professor and Head of Endocrinology at Ramaiah Medical College and Hospital, Bangalore. She has over 70 scientific publications in national as well as international journals and has contributed to 23 chapters in various books. She is a member of various scientific bodies of endocrinology and medicine. Throughout her illustrious career, she has been conferred with numerous awards and accolades. It's an honor to have you with us. Ma'am, over to you.
Yeah, thanks, Dr. Charmi, for the kind introduction. And thanks, MacLeod, for inviting me for today's meeting. It's an honor for me to moderate this meeting where Professor Antonio is the speaker. So can we have the slide of my co-panelist, and then I'll be introducing the speaker as well. So Dr. Shravanil Gadve, he is Chief Endocrinologist from Kolhapur, Maharashtra, and he's the Joint Secretary of Maharashtra Endocrine Society. He is Principal Investigator in multiple global trials, and he has trained many physicians in diabetes as well through the PHFI program. He was the Organizing Secretary of MahaEndocon 2023 also. So now today we are going to discuss about the newer updates which have been discussed in EASD, and no better person than Professor Antonio who will be talking about it. And Professor Antonio, we all know him, but just as a protocol, I'll introduce him. He is the head of diabetes department at IRCCS Multimedia, Milan, Italy. And he is the president of the European Association for the Study of Diabetes, that is EASD group, on diabetes and cardiovascular diseases. He has been the member of the board for the development of new European Society of Cardiology guidelines on diabetes and pre-diabetes and cardiovascular diseases as well. He is also served as the associate editor of Diabetes Care from 2003 to 2011 and associate editor of Diabetic Medicine from 2005 to 2016. And he has published around 450 original papers, and his current H-index is 88. So Professor Antonio will be talking to us about the newer updates, and he'll brief us on that. And then the audience are most welcome to put their questions in the chat box, which we all will be happy to discuss and answer. So I hand over to Dr. Antonio to start his talk, and then we'll have the questions after that.
Thank you very much for the kind introduction. It's really, as usual, pleasure to speak with to my colleagues in India. And I have to say that always I found my colleagues in India very, very interested and prone to raise a lot of questions. I'm going to share some interesting news which just were coming out from the EASD. Of course, the program was a huge program, So we just selected some key studies which probably are also impacting in the clinical practice. Let's start with these new molecules, which is honestly attracting so much attention and interest worldwide. And it's pity, honestly, that is available. It has been approved in many countries around the world, but it is available really only in the States at the moment. At ESD, it's been presented this post-hoc pooled analysis of SURPASS 1.4. You know, the SURPASS program is a program that included several trials aiming to needed for the approval of the drug, but not only for this, but also for evaluating in comparison to other treatment the benefit or not of the tirzepatide. And in this meta-analysis, 5 trials have been included. The SURPASS 1, 2, 3, 4, 5, and you see on the each of them against which kind of treatment was evaluated. And so at the end, you see that all these studies were including different doses of tirzepatide, because in some studies also 5 milligrams was used, in other apparently 10, and then in others the tirzepatide was titrated to up to 15 milligrams. So anyhow, these are the trials which were considered for the meta-analysis. And as you see, it's really intriguing that tirzepatide has been shown to reduce the area under the curve of urinary excretion compared to all comparators. So it's really is a very important, in my opinion, information, considering that the effect of GLP-1 analogs, as we also will see later about another study, is not clear on the kidney damage. Many are also active in reducing the albumin excretion, but in this case, you see that in any of these study, there was an active comparator. So I think that this result is really intriguing. The conclusion of the study is that a cumulative decrease in urinary albumin excretion rate was observed with tirzepatide 5, 10, and 50 milligrams versus comparators in a pooled analysis of SURPASS 1 through 5 studies. These observations were consistent across pooled placebo, active, and insulin comparator studies, and the albumin lowering appeared more pronounced in subgroup with CKD. So this is very intriguing, meaning that the drug seems even more beneficial in people with having a chronic kidney disease. In people with type 2, including those with CKD, tirzepatide decreased UACR versus comparators to a clinical relevant degree, suggesting a potential kidney protective effect. So this field is something very intriguing, because you know about GLP-1, the story, analogs, the story is not completely clear. Now, I think that we move to another aspect of which is really actual and debating, meaning there is any benefit if you combine a GLP-1 receptor agonist and SGLT2 inhibitors on cardiovascular outcomes in type 2 diabetes, because we are aware that each single molecules has already shown a benefit on cardiovascular outcomes, and there is a huge debate if it's the case to use this kind of a combination, and even is it the case to start immediately with this kind of a combination at the diagnosis. In this real-world evidence study, the inclusion criteria was diagnosis of type 2 diabetes and treatment with a dual second-line combination of GLP-1 receptor agonist and SGLT2 inhibitor, DPP-4 inhibitor, sulfonylurea, or TZD. The primary endpoint was hospitalization for heart failure. Key secondary endpoints were MACE and all-cause death. So the participants were eligible from the Danish nationwide registry between 2010 and 2021, and you see the study was corrected for several covariates. So let's summarize. 5-year absolute ratio for dual therapies with respect to heart failure hospitalization. You see here that it seems not so clear, but when for heart failure, but there is no doubt for the effect on MACE. In conclusion, in this real-world evidence study with a large study population, dual GLP-1 receptor agonist and SGLT2 inhibitor therapy was associated with a decreasing risk of hospitalization for heart failure compared with the reference treatment. Dual GLP-1 receptor agonist and SGLT2 inhibitor therapy was associated with a decreasing risk of MACE and all-cause death compared with the reference treatment. So it seems that from real life, good news are coming. But you know that another key question is a ketogenic diet can be beneficial for people with diabetes. We are speaking about ketogenic diet, which is really different from ketones supplementation. And somebody was also thinking that the ketone supplementation, because ketogenic diet seems to work, should be beneficial in type 2 diabetes. In this trial, the effect of supplements with the exogenous ketone monoester has been evaluated, and the aim was to check if these supplements can improve glycemic control. You see here the design of the study and the chart of how the trial was going on, and at the end of the day, you see that there was no effect. So the supplementing with ketones, people with type 2 diabetes, at least in a short time, meaning 2 weeks, was not accompanied by improvement in glycemic control. Also, there was not really an effect on key markers of cardiovascular risk. So at the end, in summary, unfortunately, we have to say that exogenous ketones acutely lower blood glucose in healthy individuals and those with obesity. This is referring to other studies. However, if you give daily pre-meal ketones monoester supplementation, this does not improve glycemic control across 14 days of controlled feeding in type 2 diabetes. Maybe we need more mechanistic studies to understand the underlying physiology about ketone supplementation, or much even better, the role of is in the physiology of the ketones in type 2 diabetes. The EMINENT study is something really intriguing, because I was looking at the effect of electroporation of duodenal mucosa in patients with type 2 diabetes. And this is the first in-human study which has been presented at the EASD. The study flow is really interesting, because at the baseline, the recellularization via electroporation was made. You know what so let's say roughly this procedure using electrical stimulus aims to regenerate the cells of particularly of duodenum. The aim is that with the goal that improving the regenerating these cells, the absorption of carbohydrates, but particularly even the secretion of incretins, can be improved. This kind of manipulation was accompanied by stopping insulin and having 2-week post-procedural diet. After 4 days, there was an endoscopy evaluation of mucosa to see that everything was good. After 2 weeks, semaglutide was started. Then after 4 weeks, again, the mucosa was evaluated by endoscopy. And then in the next 12 months, there was a follow-up visits with assessments. And the results really were really interesting. You see here that over time, there was a significant improvement of almost all the parameters involved in diabetes management. We are speaking also particularly of time in range, for example, also the HOMA index, but also A1C was decreased. So let's say that also metabolic parameters in terms of weight, body mass index, liver fat. So this kind of approach seems to be very promising. Conclusion, we can say, according to this pilot study in humans, that this procedure and accompanied by GLP-1 receptor agonist therapy is feasible and appears safe with the double 750 volt treatment. And the most interesting result is that this procedure leads to the elimination of insulin. In fact, 80% of the patients were not requiring any more insulin, but not only, but this was anyhow accompanied by improved glycemic control and metabolic health. Very intriguing perspective, I have to say. What about mental health? Because mental health coping strategies and glycemic management among people with diabetes in Europe is something that probably we need to know and we need also to address in clinical practice. The methodology of the study was an online cross-sectional study of people with diabetes in Europe fielded between October and November 2022. Respondents self-reported diabetes comorbidities and complications and most recent A1C level. Glucose sensor users, more than 2,000, reported their most recent time in range. Also, the respondents answered for 4 7-point questions adapted from the Diabetes Distress Scale average to create a composite variable on mental burden of diabetes. Diabetes management takes too much effort. I feel, you see this were the complaints raised by the people. Diabetes management takes too much effort. I feel unmotivated to manage my diabetes. I feel burned out by managing my diabetes. I feel overwhelmed by my diabetes. So data analysis were conducted according to IBM SPS, which is the market cited. Are two methods very well known and applied in medicine. Let's have a look at the prevalence of mental health disorders in the different countries, not only, but according to the presence of type 1 or type 2 diabetes. You see here that not only there is a difference between countries, but the most interesting aspect is that type 2 diabetes is more prone to have mental health. Probably they are older. Probably type 1 diabetes, after the first period of drama, because they need to be very careful with their disease, are more prone to accept. Anyhow, there is a huge difference in any country between type 1 and type 2 diabetes, which is more prevalent in females and is more prevalent in young people. I think that this also is not surprising. Compared to those who do not self-reported anxiety and or depression diagnosis, a greater proportion of these disturbs where adult mental health disorder have an A1C either higher than 7%, a time in range less than 70%. So these findings suggest an association between mental health status and diabetes management. I think that this is very easy to understand. If somebody is anxious, depressed, of course, pays less attention to the management of his or her disease. And of course, in this way, a worse metabolic control in terms of a worse A1C, a worse time in range emerged. So which strategies were considering in different status? You see the prevalence of, according to the kind of disease, the prevalence of a kind of approach, and not, of course, the psychiatric medication was the most common in presence of depression, but also the support from loved ones was also important. Exercise is somehow helpful, and so on. So I think that two milestones are really the support from loved ones and when needed some psychiatric medications. Future implications are that these findings suggesting an association between use of several mental health management strategies and diabetes management measures such as A1C, time in range, and mental burden of diabetes. Findings contribute to growing body of evidence in favor of integrated health solutions to mitigate the mental and physical health experience of people with diabetes. Further clinical research is needed to substantiate the findings observed today. And the same way is what happens when you use a smartphone app-based intervention on physical activity and glycemic control in type 2 diabetes. This was a study where there was an intervention group and a control group. Intervention group was receiving every week messages. So it was continuously followed by advices or just to try to remember what we should do. The control group was not receiving this kind of approach. And you see clearly in terms of physical exercise that receiving a continuous stimuli paid in terms of increasing physical activity, but also leading to a better glycemic control. So the conclusion is that app-based individualized motivational intervention on physical activity showed the improvement in step count and glycemic control, especially who were physically inactive or who had a baseline A1C levels higher than 7.5 in patients with type 2 diabetes. So it's very interesting to see that not only overall this approach was positive, but was particularly positive in people who at the baseline were inactive or were in a worse metabolic control. They were getting the best improvement using this kind of app-based individualized motivational intervention. It's something very complicated to receive continuously support and motivation to take care of your disease. And you remember the study with tirzepatide at the beginning, but in this study, the effect of adding semaglutide on top of empagliflozin in individuals with type 2 diabetes was evaluated. You see that empagliflozin was in the background, semaglutide was added, and the study was comparing the effect of semaglutide versus placebo, and there were some key inclusion criteria related to the presence of kidney disease. And all had RAS blocker treatment in the background. So the effect was null. So there was let's say there was a reduction of around 22%, but this was not significant. While of course adding semaglutide helped to increase the effect on A1C, also to was not so evident, even was not so evident the effect on body weight, probably was too short the treatment. So at the end of the day, the conclusions of this study are that the combination therapy with empagliflozin and semaglutide did not reduce albuminuria compared to empagliflozin alone in participants with the type 2 diabetes and albuminuria. The study confirmed a significant reduction in A1C, measured GFR, body weight, and 24-hour systolic blood pressure did not change. Semaglutide reduced plasma aldosterone activity, while plasma renin activity did not change. So, adding semaglutide was not effective in reducing, essentially not having any further action on reducing albuminuria. And I will finish with the presentation which I personally had at the ESD during the symposia held by the Diabetes and Cardiovascular Disease Study Group. You know, at ESD, all the study groups are invited to have their own symposia. And also this year, at the Diabetes and Cardiovascular Disease Study Group, we had. I'm going to share this because this topic got a lot of interest because it's something that probably is perceived but not well recognized yet. Meaning the possibility that the weight variability can impact on diabetic complications, particularly on cardiovascular complications. You know that to lose weight maybe is not complicated. What is very complicated is to keep the weight under control longer. And usually you have a regain of weight. In many cases, people are regain even more weight than they lost. We were able to show in cooperation with the Swedish Diabetes Registry, which is one of the best registries in the world, following all the people living in Sweden, so including, of course, all the people with diabetes. We were able to show that high body weight variability is strongly correlated to higher risk for cardiovascular complications in type 2 diabetes. And from subgroup analysis, sex seemed not to affect the results. This study has been just confirmed a few weeks ago by a meta-analysis where it's been confirmed the high variability on is body weight impacts on cardiovascular outcomes and cardiovascular variability, and it's not influenced by ethnicity or the presence of type 2 diabetes. Why body weight variability should be dangerous? The hypothesis most accepted is that this going up and down of the body weight can impact on adipocyte size, which means not only that the adipocytes grow, but they start to release more inflammatory cytokines, which in turn can induce recruitment of immune cells, so producing a chronic low-grade inflammation, which we know is the background of many cardiovascular diseases. Anyhow, you know, in one person, there is a variability not only of weight, but the variability of many other risk factors. And we know that the glucose variability, blood pressure variability are also involved in the increasing the risk for cardiovascular disease. So we were wondering, when all the parameters there is a variability of all these risk factors in the same person, which is the most important? Also, next, what is the most important cluster in leading to the high risk for cardiovascular disease? And we performed this study, again, using the Swedish Diabetes Registry, and we were able to show that body weight variability emerged as the most important risk factor for cardiovascular disease. The next step is when weight variability is combined with the systolic blood variability, which is also very dangerous, and so on. So, but I think that this is really interesting that to show that the body weight variability is probably the most important risk factor for cardiovascular events in diabetes. And of course, from this study, we have the same conclusion, which of course we can do according to our study. This study was looking at the effect of stopping semaglutide on weight. Of course, stopping semaglutide, people were regaining weight. So clearly, what is needed today is not only to reduce the weight, but in order to improve the cardiometabolic profile, and to reduce the risk for cardiovascular complication, you're able to keep the weight stable over time. And this is all for my presentation. Thank you for your attention, and I'm ready for your questions. Thank you for listening.
So thanks, Dr. Antonio. It was really a nice presentation, and we had a nice overview on the newer updates, because a lot of new things have come up. Because tirzepatide and these things showing a reduction in the albuminuria, these are all the newer things we are learning. But my question is, like, see, in a country like India, where the drugs like tirzepatide, semaglutide, these are quite costly drugs. We have oral semaglutide, we have injectable GLP-1s, but not many of our patients afford it. So what is your suggestion, like, as a country where the cost is a major factor and many patients pay out of their pocket for diabetes treatment? So what do you think are the best treatment strategies in the present scenario? Because in our country, for your information, DPP-4 inhibitors are quite cheap now because they are generic. We have the SGLT2 inhibitors like dapagliflozin also as generic. So those are quite affordable for most of our patients. But we don't have tirzepatide as such, but we are using it for clinical trials at the moment. Yes, we were part of the trials of tirzepatide. Semaglutide we have the injectable GLP-1 analogs as well, but they are quite costly. So what is your recommendation? Like, and also we do use a lot of sulfonylureas, which are almost not there in most of the international guidelines on the top or even lower down. So what is your recommendation for a country like India?
I will go more in details, but let me share that I'm chairing the IDF board of aiming to release new guidelines, global guidelines. Do we need the new guidelines? Probably yes, because the IDF, what we will try is to set 2 levels of treatment. The ideal and, let's say, the minimum, meaning that you cannot go. But we will not speak anymore about poor countries or rich countries. And let me be honest why. For example, I know I've been in India very recently. I've been several times in India, a wonderful country that really I love. But also in India, of course, maybe the majority cannot afford the cost, but there are the people who can afford.
Yes.
Go to the United States, which is supposed to be a rich country. Many people are unable to afford the cost of the drug, even of insulin, because there is no insurance. So when we speak about rich and poor, probably we have to individualize the question. So, it's not anymore a problem of countries, but it's a problem related to the people. So coming back to you, it's clear that in countries where now in India, it's very good that drugs like dapagliflozin are cheaper because they are generic. I have been for this purpose in India, and I think that this is a very good treatment. Of course, and I also think that the future, the combination with other. We will start more frequently having a combination. One of the points which we are discussing is if it's the case to start immediately with the combination, not to lose time and to favor the clinical inertia, because at the end of the day, you avoid the combination from the start, from the diagnosis, you wait too much, and then you start the combination too late. So the answer is, there are already good drugs. Of course, the hope is that everybody in the world can get the best therapy. Meanwhile, there are options, still very good options.
Right, exactly. And now, as you have told that you showed the studies of GLP-1 analogs with the SGLT2 with more beneficial effects on the cardiovascular outcomes. So, like, if we don't keep the cost scenario into the picture, like if we have a patient who has come with a new diagnosis of diabetes and we think about starting the dual therapy at least, so most of the patients would need that. So what do you think is the rationality of starting this type of combination at the outset, even if they don't have a high cardiovascular risk at the initial time, and they just come with the diagnosis of type 2 diabetes, but they are overweight or obese? Because we have lots and lots of patients who come to us who are overweight or obese, and they come with HbA1cs or 8, 8.5 or nearing 9. So do you think this is one of the best combinations to initiate?
Okay, of course, there are several reasons to could be the best, but of course we have several real world evidence already published. We also have submitted a paper where we showed that people with a previous acute myocardial infarction were having by chance a combination after the discharge where between GLP-1 and SGLT2 had a better prognosis after 1 year. And I have to say that about SGLT2, we have published one month ago in Lancet that if you introduce an SGLT2 within 2 years from the diagnosis, you avoid the appearance of the legacy effect or metabolic memory effect of glycemia. So there is a strong rationale behind this. Of course, I do not think that you can give to everybody GLP-1 plus as an SGLT2. There are other options. Metformin is still a very good drug. And maybe instead of GLP-1, you can start with the metformin and SGLT2. Of course, I'm not saying that will be not the case, but probably it's not the case for everybody to start in the same way.
True. So basically, we have to go for individualized therapy and as per what we think is the risk factor and risk categorization of the patient. Absolutely agreed. And you also talked about the newer advances in the diet. You talked about the supplementation of ketones and the 14-day follow-up. So what is your take on the dietary changes or the keto diet and the different types of food diets which the diabetes patients follow?
Yeah, maybe you know that I worked a lot on oxidative stress, antioxidant in the past. And without a surprise, we found out that no one supplement works as antioxidant. Because what you can get with the diet, you never get with the supplements. This is the truth, unfortunately, because with diet, usually you have a mix of all these substances in a different percentage, which never is reflected in the supplements. So I'm not surprised that these supplements, what I mean, maybe in some cases supplements can be helpful but you need really to understand if it's needed, because there is a need, meaning that the person is not taking enough the substance in the supplement. Otherwise, the best way is to have really good diet, good food. In India, you have a mix: good food, bad, healthy food, as everywhere in the world. Of course, I was born in the south of Italy, so this story of Mediterranean diet is more close to me. So at the end of the day, a good diet is the best option.
Yeah. Dr. Sharvil, you have also joined. So what is your take on this point, on the different types of dietary supplements which we give to our patients? Because as Dr. Antonio rightly pointed out, that may not work for every patient and may not be needed for every patient. Absolutely. So what is your take on this?
So probably we'll have to individualize that and maybe use it in some of the patients for maybe short span. But at the end of the day, the long-term management involves appropriate dietary advice, and supplements are just for a short span. So, but in special situations, let's say you have somebody who has documented deficiencies, there we are like forced to continue the supplements. But otherwise, we should depend more on the proper dietary advice.
Yeah, just to add, because in South India, we see a lot of hyperhomocystinemia, and a lot of patients are vitamin B12 deficient, and they do need supplementation because their homocysteine levels are exceptionally high. And many of them are vegetarians. So that's, as you rightly pointed out, that we have to individualize and see what that patient needs. And accordingly, we have to decide. We cannot have a blanket statement. So, Dr. Antonio, a very interesting thing which we discuss in our country and everywhere it is being discussed is diabetes remission. So, we have lots and lots of our patients who are going for it. And we know it does work and it is a concept in itself, but there are patients who are on high doses of insulin, long duration of diabetes. So what's your take on this diabetes remission in those category of patients?
I was involved let's say 15 years ago with the ADA in defining the concept of remission and cure, because of course there is a huge difference to cure and to have a remission of a disease. So remission is something that in diabetes does not exist, in my opinion. I'm sorry. What I mean, you can have a change in the fate about the pre-diabetes. But when the diabetes appears, what you can do is that you can have a good control. But in my opinion, you are not back. Because when you have diabetes, means that the beta cells, at least in terms of activity or possibility to produce enough insulin, this has gone. This is the basis. So if this has gone, until we have something which can regenerate the beta cells that at the moment is just, let's say, a dream, this concept is far from the reality. I think that what is more than remission, we can speak about keeping people in good control, which is different from remission. Remission means that the disease is not there, at least for a while. But the disease is unfortunately is there, and we must be aware that it's there, because otherwise our patients could be relaxed because they are in remission. They could enjoy more something that could be dangerous.
Absolutely. Dr. Sharvil, your comments on this, because in our country, it has become a big thing, and some patients are unfortunately not getting the right advice. So
Yes.
what do you think? Do you agree with Dr. Antonio?
I completely agree with Dr. Antonio, because we have seen that there are many long-term studies which have shown that in so-called remission, patients do relapse. So it's very important to tell the patient that, look, your HbA1c has come down to 5.7, but you need to persist with your lifestyle change, with the dietary changes. And if your HbA1c again goes high, we need to restart the treatment. So remission, it's very important that we explain to the patient that it's not forever. Even if you have achieved some so-called remission, we should be very careful and explain to the patient, because we do see patients coming back after 1 to 2 years and with very high HbA1cs. And so all the legacy effect which we talk about just goes down the drain, because the remission was just a hype. So that's very important. And probably I believe that even in patients who achieve so-called remission, that is HbA1c drops down to 5.7 even without medication, I believe we should be continuing some medication to probably prevent the manifestations. So I would like to ask Dr. Antonio your thoughts on that so-called remission, what medicine should be continued to prevent again a rise in HbA1c?
Yes. First of all, I want to point out that the most warning situation is the remission after bariatric surgery, because the people, they believe that it's over. Because in the surgery, usually it's true. You have a surgery and you solve the problem. You have appendicitis, you take off, and then you are cured. In the metabolic situation, particularly in diabetes, but also in obesity, is not like this. I also have seen people with having surgery thinking that, okay, not only you will discuss about the quality of life, but I do not want to enter in this, but then after they go back, and also some requiring insulin. About the use of drugs, I think that in principle, I can agree, because there are drugs, for example, metformin, cheap, safe, and having not only a good effect on diabetes, but is anti-aging, probably maybe anti-cancer, and also very low risk of hypo. So cheap, honestly. So to guarantee for more time and to keep the person in tight control, I should continue it with the metformin, because I agree with my colleague. The name is sorry, but
Sharvil. Yeah.
Cheryl and Dr. Sharvil and Pamela. Yeah.
I forgive me, because sometimes I think also the Italian surnames are complicated for you. So this is I think that you are completely true, because also there is another fact. If the patients continue to take a therapy for diabetes, he does not feel anymore that diabetes is over, because something is also psychological useful that, okay, you are better, you are under control, but you are not out of the problem. You are still in the same issue.
Also, Dr. Antonio, now once we're talking about remission, like even when we talk about older patients, then how lower the better? Because many times we discuss that even if we keep HbA1c very low for older people, though they may be only on very less drugs, the drugs which don't cause hypoglycemia, like metformin or DPP-4 inhibitors. So like we said, for LDL, lower the better. But do we say something like that for HbA1c for older people? Because for older people, though they may not have overt hypoglycemia and they may not be on drugs which cause hypo, but still, how lower should we keep if they are on these type of medications like metformin or DPP-4 only?
You know the famous J-shaped curve about A1C.
Yes.
So too low is, in my opinion, risky, because I can share with an anecdotic data from the Italian database. We got that in old people, meaning all the over 75, there was a large part, a huge part in good control. And when we enter in details, with very low, very good A1C, we explored, we found out that there was a lot of hypos. Meaning that you very often you get a very low A1C just because you have a lot of hypos, and this is not acceptable. It's true that you have to try to have the best, but with paying attention that you do not produce a hypos, because also the best drug not producing hypos can induce hypos. There is no one drug that cannot induce hypos.
True. So you also talked about the ELEMENT study, the one of its kind presented first time in ESD, and you showed about 86% people were off insulin. So what do you think the long-term data about this will come up? Like, do you think this is going to be an effective method for the future?
I don't know, because one of the idea is how long let's say the procedure will last. Because and I have to be honest. Okay, maybe you improve the situation, but you do not get completely free for the treatment. You skip insulin, but you need GLP-1. So the idea is the case, or you can do this avoiding this treatment. I don't know how painful it could be, honestly. I have no idea, but the idea that somebody can come in my intestine with electricity is scaring me, in principle. I think that we need more solid data, and I agree with you, long-term data in terms of safety and durability of the procedure.
Absolutely. Dr. Sharvil, you would like to ask any questions to Professor Antonio?
In India, presently, we see many patients who we give oral semaglutide. So presently, the GLP-1 agonist very commonly used in India is the oral semaglutide. One practical problem is the GI side effects with the use of GLP-1, especially oral semaglutide. So we do have problems managing patients with GI side effects. And probably diarrhea is a side effect which bothers the most. So I would like to know your opinion on how to minimize this side effect so that patients tolerate the therapy, and what strategy should be used.
You know that in the case of the use of GLP-1, the only strategy is to wait for a while, because you have a yes or no response, meaning many people after a while they overcome the side effects and they can continue, and many never will be out of these side effects. In this case, you can only stop. To minimize I don't think maybe the diet, but also honestly, I have a question for you about oral semaglutide. How is the compliance for this drug, considering, because this was a question, honestly, I was involved in the development of the drug. How is the compliance of people? Because, the key problem of oral semaglutide is how you administrate. You need to be fasting, then you need to take exact amount of water to wait. This is reliable in the real life, or people are following, or what is your experience?
Yeah, it's difficult. Completely agree with you. So prior to oral semaglutide, what we commonly used was injectable liraglutide. So we do have patients who were on liraglutide and we have shifted to oral semaglutide. But they come back telling us that over a while they feel the injectable was a good option, because following the instructions for oral semaglutide is sometimes a hassle, especially for patients who also have other comorbidities. So it's a problem for them when to take their thyroid medication, for patients with dyspepsia, when to take their PPIs and so on. So
Exactly.
yeah. So probably we are waiting for the injectable semaglutide, still not available in India. So presently, injectable semaglutide,
Yeah, no, because in Italy we had the same experience. As we discussed, it's not a secret, this was a key point, because the compliance could be not so high when you have so strict rules. And also in practice, many patients were coming back asking to have the weekly semaglutide. Why to have this torture every day? And I can have an injection every week. This was the request. Oh, yeah. Thank you for the feedback, because it's very interesting to compare what happens in different countries with different culture.
So, Dr. Sharvil, you want to ask another question?
I think we have discussed most of the points. And,
so just for the benefit of the audience, like our audience wants to know that what maximum dose of metformin you recommend. So because as we know in India, our patients don't tolerate sometimes a higher dose. So we mostly don't go beyond 2 grams, but some of the audience have raised this question that what maximum dose we can go up to.
The story is that usually 2 grams are the best. And if you go too much up, it might be 2 grams and a half, but then there is no extra effect. So if you increase the dose, there is no extra effect. This is well known. I see, but also anyhow, in a mean patient, is not the case to go less than 1,500 grams, 1 gram and a half, because 1 gram is too low. The ideal remains 2 grams.
One of the audience question is also about the once weekly insulin icodec. So what is your take on that? Will it be a game changer in the management of diabetes?
I think that you need a very special kind of a patient for this insulin, because you need somebody who, because also, for Glargine and Degludec, you adjust sometimes you adjust the dose. In this way, you for 1 week keep it the same. So you need a very stable patient, which can be benefit for this. I think that there are not so many. Maybe all the people, meaning that you accept that it is not well controlled, and then you keep because it's difficult. Then you give once a week because insulin is better than non-insulin, and so on. But the possibility to adjust the dose is very limited, because when you inject lasting 1 week, will last 1 week, and you cannot run again with so small doses of fast insulin if it goes up, in my opinion. No, but otherwise you have to check. If it goes up, you have to give some fast insulin, fast acting insulin. It's for very selected patients, in my opinion.
Yeah, true. I agree. And one more last audience question is that they're telling that guidelines incorporate about cardiovascular risk, heart failure risk, and every other thing, renal risk. But why there is not so much of talk about the NAFLD, or what we call as the MAFLD now, or the metabolic dysfunction associated steatosis? Why we are not talking so much about that in the guidelines to decide the anti-diabetic medication, or the OSA they are also asking for obstructive sleep apnea. So why we don't put these points more, because they are more of the risk factors to cause the further risk for cardiovascular disease and other things. So yes, that's one of the audience questions.
Exactly, but this, which is a new nomenclature now, the story is that we have some drugs we have at the moment one drug approved specifically for this. Some drugs were able to show an improvement of the fibrosis, but we still do not have an outcome trial. Of course, it's very fascinating to know that if you use some drugs, they have more benefit also on liver and then at the same time on other cardiovascular risk. For example, it's well known that GLP-1 can be helpful for the liver disease and at the same time also for cardiovascular disease. So you can say, okay, let's go. We can get two birds with one stone because at the same time I keep down the risk for CVD, but also I can protect the liver. But the problem also is that more than 60%, almost 60% of type 2, they have a problem with the liver. And I don't know the impact of this because you have epidemiological studies, but no one outcome trial, meaning nobody has already demonstrated that if you intervene, you reduce the incidence of at least high-level fibrosis, cirrhosis, cardiovascular disease, hepatocarcinoma. So there is no one outcome trials yet. So.
Absolutely. So, Dr. Sharvil, any comments from you or shall we close?
Yeah, I think we have covered most of the points. It was wonderful talking to Dr. Antonio, and I think we can proceed with the final remarks.
Yeah, thanks, Dr. Sharvil, and thanks, Professor Antonio. It was really a nice discussion. You have given us a lot of insights into many of the newer things and many of the things already ongoing. So I think our audience really benefited today and they were very happy with the discussion. So I hand it over now to the organizers for the final comments and closure. Thank you.
Bye.
Bye.
Thank you so much, Dr. Kalra, Dr. Antonio, and Dr. Gadve. We have had a highly engaging audience, and the audience has frequently asked a lot of questions, but because a lot of them were covered or repetitive, we've clubbed it all, and we are sure that the audience questions are also very well answered. A special thanks to Dr. Kalra for her excellent moderation, and astute thanks to Professor Cerullo for the wonderful talk on the latest studies at the EASD, and huge thanks also to Dr. Gadve for getting the Indian perspective out as to what can get implemented or not, especially from the perspective of oral semaglutide. Wonderful points which came from Dr. Antonio and Dr. Gadve. Dear audience, we thank you all too for actually taking your time to come up this late evening to ultimately join for a session. And we are very sure that the insights that have been generated in this webinar would ultimately empower you in your clinical practice and ultimately improvise on your patient care and patient care outcomes. Last but not the least, we also thank our technology partners for aiding in the very smooth streaming of this webinar. Thank you one and all. Good evening, good night.
Good night, everyone. Thank you.
Bye.
Thank you, Professor Antonio, and thank you, Dr. Gadve.
Thank you.